I think we actually might have everyone. Dr. Moss is going to be a few minutes late.
Tony Ann, I'll be in front of my camera in just a moment.
Oh, well, we won't start anything till that happens, Ross. And just so everyone knows that Jennifer, who is on, Jen, that's you, right?
Yes.
Okay. Jennifer, who is also on this meeting that you may not know, is Jennifer Denali, who is our APRN and Administrative Director of Quality and knows so much about pediatric hospice. So I asked her to jump on while we go through some of trying to decide what are issues and what are just anecdotal things that come up.
Hello.
Hi, Jasmine. How are you?
I'm doing well. How are you?
I'm good, thank you. So I think we're ready. I think we're ready to go. I think really everybody is here except for Dr. Moss. So I'm going to open the meeting, which really is, as you all may remember from the last meeting, this is really just kind of a working session to try and flush out what I feel I hear sometimes that might be just anecdotal issues and not really policy or something from a regulatory perspective that is a barrier to us providing hospice services in the state of Connecticut. And you all are the experts here, so that's why I really need to hear what you feel are true barriers that we may need from a legal perspective, help, put in our recommendation to amend, or what our regulatory, maybe from a DPH perspective, or anything like that going forward, what we're seeing from what Medicaid might allow or not allow. I think I just want to get a handle on, and Dr. Moss was in agreement, as to what truly are these things and what are just things we hear that might be happening. So we all know that with pediatric hospice, the main thing is that there's the need of the certification of a terminal illness. So we know that's a regulation, that is a criteria. But what I sometimes hear in addition to that is, if a family is getting shift nursing, and Jen, you may have to help me out here. If they're actually getting from the state, I would imagine, shift nurses, that if they go on to hospice, those shift nurses go away. Now, Ross, you're shaking your head, and so are you, like, do you hear the same thing?
Yeah, we just had this happen recently with one of Dr. Massaro's patients that had a long-term relationship with their caregivers. The family was dependent on those caregivers, and engaging in hospice would have ended up, they would have needed to stop providing that care in order to allow the hospice agency to come in and get paid.
Okay.
And were they Medicaid?
I believe they were. I wish I had. I'll try to look back and see if I can find it, because it was Stephanie on the case with me, so I can find that.
Because we've had patients like that have been on like a ventilator, and we were able to have them admitted to hospice, but their home care agency was able to stay in place to care for that ventilator.
I wonder if it's under certain criteria, like, does anybody else have any information on that? If a family has home care in the home that it would go away if they went on to hospice, or shift nurses?
I don't know about that, but I definitely can inquire internally at DSS. But my question would be if for that instance where the patient went onto hospice and then they switched companies, was there a different payer? Or was it just because the home care company couldn't provide the hospice services?
So that's a great question. The home care, Stephanie, we're talking about the patient that we recently shared that had the barrier around caregiving and then hospice care, happening at the same time. That agency that did their home care didn't have a hospice agency, is my understanding. So they weren't able to just switch them within the agency.
Gotcha, that makes sense. Okay, so then Medicaid continues to pay for the most part, but I can definitely double check just so we're clear.
That would be a big help, Jasmine, because that's what I hear a lot of, and it's like, but Jen, can you speak to, like, that we have had cases, have there been other than if the child's on a ventilator that we've been able to keep the home care in place?
I mean, I would have to go back and look, but that's the one that sticks in my mind, that because that's not something that, we provided as a hospice agency. They were able to get that through their home, a home care agency, because that's what the concurrent care is.
Right. And that's where it comes in again, the concurrent care, right? So, yeah.
Because we have patients that are on hospice and still are actively getting treatment. They go to the hospital, so.
And Jen, we've certainly had those cases as well where we've had, and Barbara, I'm sorry to jump in. I saw your hand.
No, Dr. Ross.
We've had cases of someone that we shared with Carrie that had gone to CCMC while they were on service and then came back out. And so we've certainly had that instance happen, but for whatever reason, and I apologize, our VP of operations would know this better and I can really dive in with her, but the logistics or the coverage around the home care agency versus like going to the hospital, and as counterintuitive as that is, you can have concurrent care with hospital care, but for whatever reason, we run into the barrier when it's concurrent care with additional home care support.
So the only thing that I was going to add, Tony, and I think Jasmine and Dr. Ross both captured it, that it may be payer specific, the rules around each individual payer, whether it's private insurance, Medicaid, or some other reimbursable entity. So I think we might want to identify if there are challenges. Is it specific to, I know I've heard on the previous call that a large majority of the patients served are receiving our Medicaid beneficiaries.
Right.
So it may be something associated with Medicaid, but Jasmine, thank you for looking into that.
You're welcome. And I do have the data as well that I said that I would get for you guys. But just
great.
Overview, we went back to 2019, so like kind of pre-COVID, to look at the numbers, and they really didn't drastically change as far as the cases. And so we have home health, we have data from there, and their HEDIS measures, because the claims I think would take too long. I don't, how much time do we have in this group? If we have enough time, we may be able to pull the claims data, but just to kind of get it back in a week, which is what I asked for, the data from CHN, we took the HEDIS measures to share.
Yeah, I think so. Do you mean like how long do we have for you to come back with something more?
Yes, like actual claims data.
I would, how long do you think that would take?
It may be a few weeks is what I'm thinking.
Then I would say, I think that's enough time, because we could always use it, whatever point we're at, we could always use the information when you get it.
Okay. So it sounds good.
Okay, and I think I'd also just like to add, and I know Dr. Massaro is probably going to want to, she's going to say, how many times do I have to say it? But with all of these people on the call right now, like other than that, as far as barriers, like not that, we have a nursing shortage or anything like that, are you guys living any barriers from a policy perspective or regulatory perspective other than this, where they could lose their home care if they come onto hospice, that we can address on this call?
Not from what I understand. I'm not sure if a patient had maybe some other conditions that would qualify them for Medicare at the same time, and then they were still actively receiving care in addition to hospice. That's what I've been seeing lately. Typically, well, back then people would go on hospice and that would be the primary care that they would receive. Now I'm seeing people still getting medical care, still getting mental health services. So I don't know if that would interfere somehow with the payer mix, like maybe if they were in stage renal or had a disability and they were also on Medicare,
Right,
they may have needed an acute stay, and I'm not really sure how
right.
that could affect,
Okay,
but I could see that kind of causing some complications.
right. Okay, and I don't think Dr. Moss is on yet, but it's Dr. Massaro or Dr. Albert, who, like, other than what we just talked about, are there any things that you think this group could start working on from a perspective of a policy or a regulatory issue that causes us to not be able to provide hospice services?
So I think I hopped on while Jen was mentioning the patient who's has a tracheostomy and is ventilatory dependent, because that, for some hospice agencies, maybe not yours, has been a reason that they will not accept patients. And I think that is not just unique to pediatrics. I think we see that in some ALS patients, adult patients. And I think that's a barrier because they could be mechanically ventilated and dependent on that for 20 years before they succumb to some other end organ failure. It's not necessarily their respiratory failure. So that's one. I think in any scenario, as I've said, where the patient has qualified for skilled nursing, I think something just came out today from CMS Medicaid and CHIP guidance that should clarify pediatric palliative care. I don't know if you all saw that either through CAPC. And I have to read it a little bit more, but it's supposed to clarify requirements for earlier screening and overall improved access to care. So we should make sure that we are knowledgeable in what the details of that those policy updates are, because they need to be applied to the state of Connecticut. I think that's why they were drafted.
Can you forward that to me by any chance?
So in Hospice News, it just got published. Let's see.
Can you forward it to the group, please?
Yeah, that would be great.
Yeah, if I can figure out copying this one.
Ross, do you see any other issues other than when you hit into the home care issue and getting the patient onto hospice and them losing their home care? Are there other issues that you see?
I mean, that is, I would say, of the things that I've stumbled in with Dr. Moss and Dr. Massaro, that's been the biggest one that our agency has struggled with. I can speak to that. We are an agency that is very cautious with vents in adults and in kids. So I would imagine, so I don't know of cases that has been a specific barrier, but I could imagine if it came to us, it would be a barrier. But that's, as Stephanie said, as Dr. Massaro said, you know, that's an adult issue for us as well in terms of our scope and our care that we do. Yeah, I mean, I think the question around prognostication, certification to terminal illness that we've discussed before, I've not run into that. I think that's probably been more connected to the palliative or the referring providers who send them to us. I mean, because that's an attestation that they're making that, again, they have to feel comfortable with.
Yeah, I mean, I don't think we've ever gotten sued for being wrong about,
Yeah.
you know, time to end of life. So I think we're all okay with that. I
Yeah.
guess another question I have is, like, is there room for some policy? Because one of the issues, you know, we talked about, I think it was last week, was who actually provides care to kids. And so I did speak with Ginny Zondi, our care coordinator, and I forwarded her email, I think, to Carrie. But it's really regional, and then recently Hartford. So that leaves a lot of areas uncovered. And I feel like the point of this group was to figure out how to make it more accessible. So I feel like there needs to be policy around requiring agencies to provide basic pediatric care. And then, like, to use Carrie's words, like the low-hanging fruit of, you know, at least the pronouncement or an admission and a pronouncement. But, like, is there some way that from a regulatory perspective, it may not be what's like the most ideal care, but for these places where I can't get somebody from regional and I can't get somebody from Hartford, is there room for some policy requiring that if you have someone, like if you have a nurse, or you should have a nurse, or you should be required to have a nurse that has some pediatric training so that you could care for the one-off without having one of the other nurses from one of these institutions driving 2 hours?
Have other states, Dr. Massaro, that you may be aware of done that? So the reason I pause on that is we've had similar conversations with hospitals. We have 2 pediatric hospitals in the state, but the expectation for an emergency department, if a child presents to the ED, staff need to be able to provide the care. And then once all of the EMTALA requirements are met, then they can transfer to a children's hospital. But I'd be interested in if you have any awareness, or Dr. Albert, or anyone else on the call, if other states have done something similar to this. And having said that, I think it would also be helpful to understand what the barriers are, or the perceived barriers from the industry in Connecticut, that why aren't you doing this?
Well, I mean, I think the barriers are that it's what we talked about at the very beginning. And so this is why Yale is taking a different approach. But the barriers are that you have nurses who feel comfortable in providing end-of-life care in the home to adults. And then we try to suggest that they take care of a child. And we do a lot of raising of the flags. We don't do that in kids, and that's not how, you know, dosing is different in kids. I mean, there's a whole Riley Haynes course on how to transition an adult hospice care provider who's interested. They have to have the interest to begin, right? Because there's a lot of fear in caring for a child at end of life. Because you're really caring for the entire family. I think we've talked about that as well. So there's the issue of just like they're just not comfortable. So then if you do the opposite and you find like a pearl in terms of a nurse, a hospice, you know, a home hospice nurse who actually took care of kids at some point, and so they don't run screaming, and are willing to engage and jump in and take care of kids. But there's just not enough kids dying, thankfully. And so then to supplement them and make it like fiscally sound, you have to ask them to go take care of adults. And then they have the same response of, I'm not doing that, because that's not, like, I'm not taking care of an adult at end of life. I fear the day that happens. I don't know what I'm doing. So, you know, with all the utmost respect to their professions and their training, we're trying to fit, square pegs into round holes when we ask these care providers to do that. So I think that's a major reason why. So, at Yale, we're trying to come up with a way to be able to take skilled pediatric nurses and plug them into home care opportunities by cross-training them with those who are familiar with taking care of kids. And currently in the state of Connecticut, it's like 3. There's like
I
3
think we're
nurses.
talking about that again tomorrow, aren't we?
Yeah. So, I mean, it's a fabulous endeavor, and I wish I could claim all the responsibility for that thought process, but I have great nursing partners at Yale, so I'm hopeful for that. But I think there's also going to be, if Yale does it right, there's still going to be areas where we can't reach because we can't have one of our nurses who's doing a cross cover shift driving 2 hours to get to a kid. And the goal is to keep the kids in their home. If they want to be in their home, then we have to figure out how to partner with these agencies who do reach those smaller areas. And whether there's some way to subcontract for right now your load's not too high in terms of pediatric cases, so can we contract your nurse, or is there a per diem rate we can do and get them in there? It doesn't really get around the fact that there's only 3 nurses in the state of Connecticut and they live in New Haven and Fairfield.
Right. Right. And one other thing is, because I like the approach of, if the state has given you a license to do hospice, that should be from 0 to 100 and whatever, right? You should have to do the full spectrum. But like Dr. Massaro is saying, that's what we're finding is, you can't find the nurses. So then the concept of partnerships with certain universities that want to come and have nurses train at a hospice. And we would be more than happy to be one of those. But then those nurses need to work and do the work in the state for 1 to 2 years if they're going to get incentivized by the state to do this. We need them to stay and work. I mean, that would be, that would be the other thing. But yeah, that is when we go away from what they're doing about, taking away agencies and this, that. I think really the root cause and the root issue for where we're at right now is nursing, is that some agencies and even some of my colleagues who are nonprofits will just say, not going to do it. Not going to pay for a specialized nurse and not make enough money on pediatrics and be at a loss for it or a break even, which to me is not something that you should get to choose as a nonprofit.
Yeah, legislatively, I think about it also in the context of, Barbara, you had mentioned pediatrics, but we do this with labor and delivery floors in Connecticut, it feels like, where we know there are gaps. In hospice itself, we've got CMS makes hospice agencies be able to do all 4 levels of hospice care. So, if you're not able to do continuous care, respite care, GIP routine, you're not meeting their standards. I mean, so I guess maybe that's the closer parallel, is to say that's an expectation of a hospice agency. Should Connecticut say that doing pediatrics is an expectation similar to doing those 4 levels of care?
Right. And that's kind of why I wanted to have this meeting, because I feel the first thing is we go a lot to, well, what are the barriers that are causing us not to provide this that we can amend and change? That's this much, right? It may be the loss of the home care if they come onto hospice. It's, the other things that, maybe families are not comfortable with the word hospice. Can we call it something else? Can we make the certification be 1 year instead of 6 months, or somehow reword it? But really, when we get down to it, some of the real problem is, how do we provide the care, especially for the agencies that want to? Because I have no problem if I was going to even connect with oh God, what is her name? I think Erica from Day Kimball. Even if we were going to connect and say, I'll even help you find a nurse and you service that part of, the state, and we can do it in partnership, I would have no problem with that. But we need the nurses to train and to stay in the state. How do we get that done?
Mhm.
Sorry, it's Karen from Yale Hospice. I know we talk a lot about nurses, but we need the other team members too. We need social work, we need spiritual care, I know we need to start with the physical care.
Yes. Yes.
And sorry, I
100%
dropped
agree.
on late.
Yeah. No, I agree 100%. I have to say that it's for us. All right, Dr. Moss, I may not make it today. Sorry, no problem. I totally agree with you. And like you said, the nursing is probably the hardest thing to find. That's, so do we try and say, okay, Yale, you're Yale, right? You can train these nurses and you have kind of a pipeline that can feed your training. We are happy to partner with anyone that wants to come and train here. And I think that's probably the biggest thing we're looking at. And I have to go back to some help with state funding. And we've even been asked, well, if Medicaid increased their rates, well, I don't know if Medicare is going to increase their rates because they follow Medicare, because Medicaid follows Medicare. I don't know if that's ever going to really happen to the point where we can actually pay for full-time experienced specialized nurses to take care of kids. But I think we need some type of funding.
Yeah, even for the training, we are fortunate. We've been taking care of PD patients for a while, and we have the pearls. We have the nurses who will do just PDs or PD and adults. So we've been very fortunate with that with the team. So we've been able to really partner with all the hospitals to get that done.
Right. And then, where we struggle sometimes too is that we're an APRN driven agency. We have a medical director, but our APRNs really run our agency. And you can't do it with one family certified APRN either. We need another one who can help cover nights and days, and when it is different, the differences in dosing. And you're not certified to do, if the patient needs to come for an admission, we can't do an admission. So there's just back onto what Karen said, like it's the nursing, it's the AP, the NP, and social work. So it's a couple of things that I think we need to put in the recommendation, that it's not just amending certain things, it's actually developing. And how do we develop a program where nurses are being trained in pediatric hospice and stay working here?
So Tony, would this group indicate that staff recruitment and perhaps retention is the number one barrier? So
I think so.
There exists the Office of Workforce Strategy that was convened towards the end of COVID to address the healthcare workforce shortages. I wonder if this would be a place to perhaps discuss with them. Could they build this into their work plan to expand or do some training, expansion of the workforce to perhaps improve the situation a little bit?
Right. And how do we as a state incentivize nurses to go into pediatric hospice? Like, how do we incentivize them to do that? And we will provide the training. And, this was Senator Anwar when he came to see me. He's like, we have to figure out, you know, and maybe it's not as easy as just recommend it, but yeah, what is the plan for that? How do we develop a plan that would allow nurses to be incentivized to go into and train in pediatric hospice, at least as a rotation?
Right. Yep, I agree with that. Tony, so thanks
Yeah.
for sharing. Barbara, I actually was thinking about that as well, but I was thinking about how to connect the two. With the grant from Office of Workforce Strategy last year. And they were trying to figure out how to increase the amount of nursing students and start different nursing programs. And Eastern now has one, I believe, as a result of that grant. I think that would be really good if we were to touch base because they're even going into like the schools and having the students go to certain facilities and hospitals. So having that as a rotation would be great because there's so many nurses who want to do neonatal nursing. They have the interest in children, but children and hospice, they're two major specialties that you just have to be interested in it. You don't always get experience with it. I will also say from the DSS side or on Medicaid, if there is a need, anyone can always submit additional documentation to say, hey, we need help with this. And it can be reviewed by the clinicians on my unit. And we can see if, you know, it's medically necessary that this care gets rendered to whatever member it is. So it's not, the policies are there as guidance and they always state that. But in the event that a situation is just an outlier, it's different, it's medically necessary that someone receives a certain level of care or maybe an increase, but an increase in pay possibly.
Wow.
DSS is always available to review those cases. We do them all the time on our unit. Understandably, this is a very rare case.
Right.
I don't know where the like funds would come from in general to support legislation, but again, we can always review any case. So I just want to kind of throw that out there.
Well, Jasmine, that's great to know. So thank you so much for sharing that.
You're welcome.
Jen, oh, I'm sorry.
As I'm listening to you talk, I want to ask you and Karen and Ross, like, about this thought. We talked about folks, other providers other than other than nursing. From a behavioral health standpoint, we encourage patients to elect their hospice benefit so that we can secure bereavement support. And as I understand, currently it's 13 months of bereavement support if you elect your hospice benefit. So I'm curious about whether or not you feel that your individual agencies and collectively are actually able to meet that need with the resources you have. And if so, or in addition, it feels to me like there are children, you know, who die suddenly, either by SIDS or SUDS or an injury. I'm thinking of a patient that I recently cared for that had chronic illness. We've been working with family from a palliative care perspective to outline goals of care, and mom was slowly moving towards, you know, transitioning goals that away from sort of life sustaining and more towards quality and comfort. But he had an unfortunate event and ended up dying at home unexpectedly, so to speak, and was in the ED and resuscitated unsuccessfully and died. No access to anything. And I wonder about whether or not there's room in that stratosphere for using this opportunity to improve. Because to Carrie's point about an admission and a pronouncement, what are things we can do to sort of help support the experience of all kids? And if not all kids, you know, so there's a portion of kids with chronic illness who do unfortunately die suddenly. And those families are largely unsupported. And similarly, there are kids who die by trauma, and those families may or may not be accessing their appropriate support. So is there opportunity there? Do you feel like you have the support you need from behavioral health for those folks who elect their hospice benefit, and would there be something that we could try to do or ask the state of Connecticut to do, such that if they're at least enrolled or had a palliative care consultation, that we could support them via palliative care to get them connected with bereavement supports, should something untimely happen before we've elected the hospice benefit in its totality.
So
Certainly.
go ahead, Ross.
Oh, I'm sorry. I was just going to say, certainly, and I would imagine it's similar in the Yale system. We certainly hear that ask periodically from our hospitals, even for our adults that have sudden ICU deaths or other things where they're and in the past, our hospice team has done support groups and some bereavement with the hospital palliative care teams to do that. It is not as formalized as a 13-month hospice bereavement program, you know, which you would expect. Within our system, I can say from experience, we've done it, but outside of our system, I think it's been pretty limited.
It's the same for us in Yale.
Yeah, so at regional, we have provided it, obviously, you know, when they're on service, and we're actually just going to start. I don't have the exact date yet, but loss of a child group. We're going to start that, and we have in the past have supported others not on our service with bereavement, with, you know, either coming in as a group or even, you know, as a one-on-one. The one-on-one is a little bit harder for us. The group is a lot easier to have others participate in that have not been on our hospice program. I mean, we started a whole grandparents group after Sandy Hook, and we also did parents. So yeah, we will go outside of, you know, those that have been on service and provide bereavement. But like I said, it's probably more so in a group setting than a one-on-one. But I'm happy to, you know, think about that further if the one-on-one would be more beneficial than like a group setting.
And I might suggest when we've had people who need bereavement support that's more specialized, whether it's for pediatrics or even a particular language that a family speaks, where we know we have a chaplain who speaks a particular language, for example, we can pull people from across the state. I would say that the acuity of while someone's on hospice and needing social work support, needing that person locally, that's probably in real time. That's what, to your question, Stephanie, around, you know, do we have the resources? We have excellent, and I know Regional and Yale and, you know, other agencies have excellent social workers. I think if you ask them, there is probably a crossover similar to the nurses who would say, I'm very comfortable talking about bereavement with a grown-up, but I could use some help, you know, in the nuance around talking about it with kids, with families, with siblings, you know. So I think there's room for improvement and room for education, I guess is what I wanted to add.
Thanks. I think that that's an area where we need to put some amount of focus. I think of our social workers are fabulous in oncology, and they do follow up bereavement care, but it's very limited. It's certainly, you know, not the same as a, you know, commitment to a behavioral health provider relationship around grief and loss. And so I think what we're missing some folks there. And it's a circumstance that if you don't happen to elect your hospice benefit, that you won't then lose access. I mean, some of those folks, I think, access mental health supports via their own, you know, insurance and community referrals and such. So I don't have an exact feel, but I do think there are some folks who, you know, some areas where we could improve what we offer as part of the hospice benefit, because I think it's uncovered in a lot of ways. And physicians don't, we try, physicians and APPs have tried to bill for bereavement, and it gets bounced back to every time. So because it needs to be a certified mental health provider. So we're doing it, but it's like that area where you're doing it. And, I've done a lot of things for free for a long time. And we're doing it because it's the right thing, but there should be an improvement. And I think that's a statewide need from what I've just heard. So that I guess I envision something that if you have a palliative care consult, if you could elect palliative care home services through a home care agency, that you then, it would be ideal to elect your hospice benefit. But if you don't, you still should qualify if the child has an untimely or sooner death than one would have expected, and you just hadn't gotten to that election. But anyhow, that's just one piece of it all.
Right.
Can I ask a clarifying question? So are you looking for that a hospice agency would provide the bereavement services, or that behavioral health would?
Well, so it has to be a behavioral health provider within the hospice agency, right? It's not, I think you could go at it a lot of ways. I guess my point is that, and I'm thinking of a specific population in which the child has Medicaid because they were born here, or they acquired, and so we care for them. They have their disease-directed therapy. They have a chronic illness. We're not going to affect their disease trajectory. The family has not elected the child's hospice benefit, so they have not secured 13 months of bereavement. And the child dies unexpectedly, and their parents are left with no bereavement support, and they may not be documented. They may not have health insurance. And so they're missing out on opportunities for bereavement, which in order to bill for it anyway, it has to be by a behavioral health provider, because they themselves don't have insurance, where they could have accessed it through their child's benefit.
And I think
I don't really care who it comes from, but
I think the reason, Karen, correct me if I'm wrong, I think the reason that question came is most hospice agencies, I think almost all, generally the mainstay of their bereavement support is going to come from their social workers and their chaplains.
Yeah, and the bereavement
from
coordinators.
Psychologists and psychiatrists. So that's,
Yeah.
I just wanted to clarify that piece, that's all.
Yeah, because we don't bill separately for the bereavement services.
I understand. But if
Kristen, you want to do it.
Well, if Kristen and I were to try to provide bereavement support and then drop a bill for bereavement, it doesn't get paid. Because we're not certified mental health providers. So as physician APP, it's not going to get paid. But that doesn't. So I guess I'm looking for you get to bill once they elect their hospice benefit. If you provide continued bereavement support for 13 months, you're billing, and that bill is going as part of their hospice benefit. It's going against the child's medical insurance, but
we actually don't bill once the patient dies. We don't bill.
We don't bill either.
It should be reimbursable if you're offering it from a mental health provider for 13 months.
Not under the hospice benefit.
Not
once that
hospice.
Patient dies, the billing ends, and we provide that as part of what we were reimbursed for their hospice care.
So it's like prepaid.
It's part of the per diem rate.
There's some investment into it, so to speak. I'm not saying you're getting reimbursed well. I'm not saying it. I recognize that from family to family, it may vary. Someone may take hold of it. Other people may not. I understand that, but there's just no mechanism to secure bereavement for other, patients who then, they can access their bereavement support through your agency for 13 months following the death. But if a child is not, the family did not elect their benefit in time, and the family has no health insurance, they're not going to be able to access any kind of support.
Yes.
Correct.
And even if we did support them, we then can't bill for those services. It would be like any of the groups that we all do that we've just talked about. We don't bill for those. Those are just something we do for our community.
And when we talk about like the low hanging fruit, we say, well, to do an admission or to do a pronouncement, and if we had nurses and things like that. But when you're saying a pronouncement, it would be the patient is not on hospice, has not elected their hospice benefit, but they die at home. And we're looking for someone that would be able to go out and pronounce so that they don't have to go to the hospital to get pronounced. Do I understand that correctly?
I believe that was Carrie's intention.
Okay.
I think that works well for a patient who's connected to palliative care subspecialty services. There would still have to be some referral pattern, right? Because if you haven't elected your hospice benefit and you're not necessarily connected with a palliative care provider and you happen to die at home unexpectedly, it's sort of a different path, right? Even if you have chronic illness for a child, there's still potentially a different path that involves like an ME exam, like, there's things that go outside. So I think I don't want to speak for her because she certainly has more years at this and expertise, but I think what she was envisioning is some sort of like admission to home and some availability, once it's been discussed and documented that the child is not returning to care, that the goal is to die at home, to then be able to be pronounced and not have to be transported. I think we talked a little bit about this in the context of with COVID, they extended paramedic, EMT pronouncements, right? And I don't know where any of those are right now. And I don't even know how those folks feel about doing any of that because that's not usually what they're doing, right? They're usually going out to try to resuscitate, stabilize, and transport. So I understand that request. I think it does miss the big picture, which is, I think when parents decide to take their children home to die, they don't necessarily understand the scope of a hospice philosophy as it was outlined for adults, which is that their spouse, their adult children are assuming the patient's care, the acuity of their care and the management of their symptoms with some guidance, via telephone, via intermittent visits. I think a lot of families, like the family we sent home more recently with Hartford, they got home and they wanted him to be at home, wanted to be comfortable at home, wanted to have visitors, didn't want him to return to hospital, like had a plan for an extubation. It was as good as it could have been, but then somewhere along the line, whether it was one of our ICU providers or another family member, someone had some expectation that the nurses were going to be with them 24 hours until continuously until the child died. And we had to like sort of backpedal that and say, no, that's not how it works exactly.
Right.
So I think it misses by saying, yes, we can assure that someone can come out and pronounce, kind of shortchanges the actual work that gets done in terms of supporting the family and making it so that in truth, neither of the parents or the other providers and family who are in the house actually are living with this responsibility of administering a dose that then results, because we all know that's not what happens, but to a lay person, that is what happens. And we work a lot on saying it's the disease and it's not, there's nothing, this was the plan, this is how, it's a lot, right? So psychosocially and emotionally, it's a lot. And so while I think it's important to keep kids at home after they die, and the parents who don't want their kids to go back to a hospital and sit in an ED, wait, or be pronounced and have to go to a morgue, and we want to avoid all of that. I think that's very true and very important. I don't think we can totally sidestep the work you do in the home. So I think we should be mindful of that too.
I think the work is so important. We were worked with Dr. Moss. It was the first time we were asked if we could go and take care of a patient. And we had the trained staff. We happened to have people who it just fell into place. It was beautiful. And she called at one point and she said, could you even just go do the pronouncement? Like if you could just do the pronouncement. And when I think about that case and what we were able to do to support the parents and the child and her sibling and how beautiful it was, like, just to go do a pronouncement I just feel it's almost it's a service, but it's a disservice. Like I really would like to have like a more robust, like a focus on how we can ensure that they can get the benefits of the services we provide.
Yeah, and I mean, I think when, again, Carrie can probably explain her thought better, but I think when you come at it from the perspective of having done this a really long time in a system that has so little resources, that leaves most of us who want to just get kids home so desperate to be able to do that, that's you
got to find a way to make it happen.
Yeah, like, and so at the end of the day, it's like when we ask that, I think this is a family who's been in the trenches, their child's been getting chemotherapy or has been in a chair, and like they've been doing this for a long time, and we feel these are the parents that are most equipped to accept the limitations, which is someone will come and pronounce your child, and like that is sufficient enough. But I just wanted to sort of add that, like, I think if we have folks' attention, and the goal of this is to improve this system and the services, and as laid out in this field of dreams, without any disrespect, but then I think we should be asking for it. Then I think we should be outlining it. This is the opportunity we have to say we have to do better, and that kids deserve and their families deserve more than just the bare minimum.
And I think actually when we first started like looking after children, I'd done some research, and I will find the article. I think under the Affordable Care Act, there is something specific to pediatric end-of-life care where treatments for patients up until 18 are carved out, and some of these other things are carved out. So that might be helpful in terms of when we're looking at how do we pay for this. I'll find that article and send to everybody.
Karen, that would be great. And so, I mean, I guess basically what I'm hearing also is that it's, you could still get these kids home, but you're then faced with the family that's not prepared, and the nurse is not going to be sitting there for 12, 16, 24, 3 days. And you also have the family who is prepared. I mean, and we even see that now in adults, right? That think that they're going to be able to handle those last 3 days of death and the actual actively dying patient, and they can't. So it's almost the same kind of thing. And Karen, when you did it, what were you able to provide to the family? Like they were discharged home.
They were discharged home. We had a nurse and social worker go out for the initial visit. We provided spiritual care. We provided all services. We actually had volunteers in there as well.
Right.
And it was just, they were very well prepared. And again, I think a lot of it was they were prepared from the time of discharge too. They really just wanted to get this little baby home. But yeah, we did the full gamut of hospice with them.
Okay. And that we're doing that right now. We're actually, tomorrow is the first training. We're going to be training volunteers. We have volunteers now that sit vigil like with adults and go with families but now we're going to start training them for pediatrics specifically, because that is what we see. Sometimes it's just that having that other person there that can sit with the family while they're going through this. And of course, there's always, if you needed, if it was a crisis kind of case, continuous care or something like that. But yeah, that's definitely something that I think we should put in this recommendation of what hospice care should look like for that pediatric family that's going to go home and the patient is going to die. They're not going to be home for a month, so I think that's important. But if you could pass on that article, that would be great.
I will. I'll get that for you tomorrow.
Okay. So I think we kind of covered a lot today. Does anybody else have anything to add that we should keep in the forefront of our minds? Okay.
Tony, and just before we end, would it be helpful if we were able to make a connection with OWS to see what they may be able to do in terms of support with recruitment and retention?
Absolutely. I think every possible resource, I think, would be great.
So I can see if I can make some outreach to the contacts that I worked with in the past, if that's helpful.
Yeah. Yeah, that would be perfect.
Or at least, at the very least, identify the problem that has been noted in the pediatric hospice sector
Right,
regarding retention, recruitment.
right, exactly. Because I think we have most of our work has to do with, you know, things that don't need to be amended per se, but maybe put into place as policy, and what to me, any hospice that's you know, has a license to do hospice should be doing the whole array of hospice. And how do we get there? And part of it would be that we need people to do the work.
Right, right. That's the biggest challenge,
Right,
is have the bodies to do the work, and then having a competent and skilled workforce to do the work.
exactly.
I don't think any of us want to have cardiac surgery in a hospital that doesn't have the specialty services to do that. So we want to make sure that there's competent care in these pieces of the sector, or points on the sector.
100%.
Thanks, Barbara and Tony. I have a question. I may have missed this. Sorry. Have we looked at literature to see like if there were any recommendations of what to do in situations like this, or other states, and how they handle pediatric hospice care?
I think we were waiting to hear back. Tracy did get in touch with both Massachusetts and California, I think it was. I have not heard back from her, but when I look at pediatric hospice nationally, those are really the two places that do it best, and other places, most other states have the same issue we have. So I think we probably really need to hear back from Tracy about how they're doing it, especially in Massachusetts.
Thank you.
Carl shared the link to Massachusetts, and Jasmine, you may be very interested in the Massachusetts program. It is, I think it's a publicly supported program.
Yes, it is. Yeah.
So it'd be interesting to see how they do that. If I could send you the link so that it's at the top of your email if I can find it.
Thank you. I'd appreciate that.
I believe, do you mean like they're actually funded by the state of Massachusetts?
I did a quick read, and it looks like there may be public dollars that are supporting the program.
Yeah, I did see that.
It is. It was established as part of the universal healthcare law in Massachusetts in 2006. It was initially funded through that bill, and then it's been funded through the a general appropriation fund each year since.
Yeah, thank you, Brian, because that's key for us, right? So that's a big part.
I can also, it's a small piece and it's a symptom management issue, not a problem solving issue. I almost think of it, the question around the EMTs, we have a connection with Hartford's, we own an ambulance agency that I think I would have access to their leaders, and maybe also then get to some state leaders. If there's an organization of medical directors or something for the EMT agencies, I wonder if they've got any stance or position on how they might be able to support some of the gaps we're talking about. Again, admittedly, that's not solving the problem, that's filling a gap, but it's worth asking at least to see what they've talked about.
I can do the same for our area. I know that I went out on a pronouncement for a pediatric patient that was out of our territory at that time, but pediatric, we took it, it was in Waterbury. And we were literally in the process of that. We would only go out to do pronouncement with police escort, because there was just a serious issue about the estranged father and things like that. Anyway, the EMTs were there when we got there, and we went in to pronounce, and the EMT said, we had said, oh, you guys were here. And they said, but we will never pronounce, especially a pediatric. So maybe things have changed. This was like a year ago, but I can reach out and ask too, but they were pretty clear.
Yeah, I'm channeling Stephanie's energy of saying it can't hurt to push or ask.
Right,
So
absolutely.
that's why, so yeah.
Absolutely.
There is an emergency medical service committee within the state of Connecticut, and actually, oh boy, probably 10 years ago, they were actually trying to affect some change around language that we use for all patients to move away from DNR, DNI, and to A&D or and allow natural death terminology and changing those orders. And I'm not so they exist, and I think there is a portion, there is some platform there. I'm not surprised that they don't want to pronounce. I know of it happening once during the pandemic with a patient that was, I believe, with regional, and we were all set up to do what we normally do, but they came in and they did it, and then they left. It wasn't a good experience because they didn't do the things the hospice nurse does, which is, okay, we know we decided on this funeral home, and we're going to call this person, and we're going to help you clean out the medicines. And like, it was just, for the family, it was almost more devastating. So I'm not suggesting
Right.
that that's the fix. I'm just saying, like, I'm trying to figure out ways to cover these.
Absolutely.
So
Yeah. Okay, well, I thank you all so much for your time and your patience and your passion for this. And I really would like to be able to work more as a on certain things as a work group and kind of report back on a monthly basis. So you may see, I'm going to talk to Dr. Moss about this meeting, and then you may see another meeting come out for a little bit more of a work group again, and then we can report out like at the monthly. But I so appreciate your time today to come on and help us work through some of these issues. So thank you very much.
Bye.